Hey everybody, Heather Murphy here. Let's make endocrine a little less scary. Starting with the thyroid, think axis first. Hypothalamus releases TRH, the pituitary releases TSH, and the thyroid gives us T3 and T4. Then those thyroid hormones feed back and tell the brain, okay, we've got enough. That feedback loop matters because it helps you read labs instead of just memorizing them. Now, NCLEX loves comparison. Hypothyroidism is the low and slow patient. Everything is sluggish. Common causes can include autoimmune destruction, like Hashimoto's, thyroid surgery, or treatment for hyperthyroidism. You'll usually see fatigue, weight gain, cold intolerance, constipation, dry skin, bradycardia, and slowed thinking. Labs often point to low thyroid hormone, T3 and T4. And in primary hypothyroidism, the pituitary tries to compensate, so TSH tends to be high. Hyperthyroidism is the opposite, high and fast. Causes can include Graves' disease or other states of excess thyroid hormone, those T3 and T4 labs. These patients look revved up: weight loss, heat intolerance, diarrhea, tremors, anxiety, tachycardia, maybe palpitations. Skin can feel warm, and they may seem restless or just kind of unable to settle. In primary hyperthyroidism, thyroid hormone is high, so TSH is often low from that negative feedback. If you forget everything else, remember the pattern. Hypo, low, slow, cold, constipated, tired. Hyper, high, fast, hot, loose stools, jittery. That simple cue helps a ton at the bedside. And don't separate symptoms from safety. A slow heart rate and decreased mental status in hypothyroidism, that should get your attention. A racing heart and agitation in hyperthyroidism, also a red flag. One more little teaching pearl. Don't chase one lab in isolation. Look at the story, the vitals, and the trends. Endocrine questions really reward that whole picture thinking. So once you recognize the pattern, what do we do? For hypothyroidism, levothyroxine replaces thyroid hormone. Nursing-wise, teach consistency and monitor for signs that the dose is too much, because then your low and slow patient starts looking a little high and fast. For hyperthyroidism, antithyroid meds reduce hormone production. Beta blockers help control the sympathetic symptoms like tachycardia and tremor. Radioactive iodine may destroy overactive thyroid tissue, and some patients go to surgery. Post-op thyroid patients need close airway monitoring, bleeding assessment, and you also want to think about the parathyroids because they sit right there. If parathyroid function drops, calcium can drop. And that brings us to a quick compare and contrast. Hyperparathyroidism generally means higher calcium levels because calcium has moved out of the bones and into the bloodstream. Hypoparathyroidism means lower calcium levels. Low calcium is the one that makes me sit up straight because of neuromuscular irritability, tingling, cramping, and seizure risk. Two thyroid emergencies you absolutely want to know: myxedema coma and thyroid storm. Myxedema coma is severe hypothyroidism turned dangerous. Think profound, low, and slow. Decreased mental status, hypothermia, bradycardia. This is not a watch and wait situation. Support airway, breathing, circulation, monitor vitals closely, and escalate care fast. Thyroid storm is severe hyperthyroidism. Think extreme high and fast. Fever, marked tachycardia, hypertension maybe early on, agitation, and that patient can deteriorate quickly. Priorities are cooling, monitoring cardiac status, giving ordered meds like beta blockers and antithyroid therapy, and staying very focused on hemodynamic stability. So the nursing lens here is really assessment, labs, and safety. Read the trend. Is calcium high or low? Is the patient slowing down or speeding up? And what can hurt them first? Airway, heart rhythm, neurostatus, or fluid balance? That's the NCLEX way to think. Okay, next comparison, SIADH versus diabetes insipidus. SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone. I always tell students to start with the hormone. ADH, antidiuretic hormone, helps the body hold on to water. So if you have too much ADH, that's SIADH, you retain water. If you have too little ADH or it's not working well, that's diabetes insipidus and you lose water. In SIADH, the patient is holding on to excess water, so the blood gets diluted. That means sodium can fall. Think headache, confusion, maybe worsening neurochanges if it gets severe. Urine tends to be more concentrated because the kidneys are reabsorbing water instead of letting it go. The big nursing priorities are fluid restriction, monitoring sodium closely, watching neurostatus, and preventing complications from hyponatremia. Diabetes insipidus is the flip side. The patient is dumping huge amounts of dilute urine and getting dehydrated. So now you're looking for excessive thirst, dehydration, dry mucous membranes, hypotension maybe, and all that fluid loss can push sodium up. Urine is very dilute because the body is not holding on to water the way it should. Here's the memory cue. SIADH is soggy on the inside, diluted serum, concentrated urine. DI is dry on the inside, concentrated serum, diluted urine. Not perfect science language, I know, but it works when you're stressed on an exam. Treatment priorities follow the problem. SIADH, restrict fluids, monitor sodium, seizure precautions if indicated, and keep a close eye on intake and output. DI, replace fluids as ordered, protect from dehydration, monitor sodium and hemodynamics, and desmopressin may be used when appropriate. If the patient with DI is getting more tachycardic, more hypotensive, and more dry, don't miss that. That is a safety issue, not just a lab issue. Last compare today, Cushing syndrome versus Addison's disease. Same trick, start with the hormone. Cushing's is too much cortisol. Addison's is adrenal insufficiency, so not enough of those adrenal hormones. Once you know whether there is too much or too little, the rest gets easier. Cushing's looks like cortisol excess. These patients can have hypertension, hyperglycemia, fluid retention, weakness, and skin changes like thinning or easy bruising. They may also have that classic rounded appearance, but for NCLEX, I want you locked in on the safety stuff: blood pressure, blood glucose, infection risk, and skin protection. Treatment depends on the cause, and some patients may need surgery or medication changes, especially if steroids are involved. Addison's disease is the opposite picture: not enough adrenal support. Think fatigue, weight loss, hypotension, weakness, dehydration, and often low blood glucose concerns. If Cushing's is too much, Addison's is not enough to maintain stability. These patients may need steroid replacement, and teaching is huge. They can't just stop steroids abruptly if prescribed long term. That can be dangerous. And then there's adrenal crisis, which is your emergency. Severe hypotension, worsening weakness, dehydration, maybe altered mental status. That patient needs rapid recognition and escalation. So again, nursing priorities are really practical. Monitor blood pressure, monitor glucose, assess fluid status, give steroids as ordered, and be alert for crisis signs. If you want one last memory cue, Cushing's is cushioned with excess, Addison's is add it back because the body doesn't have enough. A little corny, but hey, if it helps you answer the question and care for the patient safely, I'm good with it. I hope this helped you with endocrine comparisons, because once you see the patterns, this content gets a whole lot more manageable. Until next time, happy learning and studying!